Welcome everyone. Today I'm going to talk about the GERD, its pathogenesis, risk factor, clinical feature, diagnosis, and management of GERD. So the GERD, before discussing the GERD, we should know about the anatomy of the stomach and esophagus. Here you can see this is the stomach and this is the esophagus. In the stomach and esophagus are connected to each other through a junction which is called a gastroesophageal junction. And there is a circular smooth muscle in between the junction of the stomach and esophagus. This circular smooth muscle is called the lower esophageal sphincter. Abbreviation which is come from the gastroesophageal reflux disease. Gastro means stomach, esophageal means esophagus, and reflux means backflow and disease. So it is the backflow of the stomach contents into the esophagus. This condition is called a gastroesophageal reflux disease, and it is also called the reflux esophagitis. Reflux means backflow. It is the backflow of the stomach content with inflammation and irritation of the esophagus. So the pathogenesis, there are two things. One is the transient relaxation of the lower esophageal sphincter. Normally when there is no swallowing, the lower esophageal sphincter become relaxed, which actually expel the gas produced in the stomach through the esophagus. So during this normal relaxation, the stomach content may flow into the esophagus and can cause the inflammation and irritation of the esophagus. And the other is incompetent lower esophageal sphincter. When the esophageal sphincter become unable to contract properly, it will cause the stomach content to flow into the esophagus. So the risk factors, the first risk factor in the GERD is the hiatal hernia. Hiatal hernia is actually the bulging out of the upper portion of the stomach into the chest cavity through the esophageal hiatus, which exert pressure on the lower esophageal sphincter, which cause the backflow of the stomach content into the esophagus. The other is delayed gastric emptying. When the food is in the stomach for longer time, it will transient relaxation of the lower esophageal sphincter. The stomach content can goes into the esophagus. The other is mucosal reparative mechanism become decreases. Normally when there is any injury to the esophageal mucosa or the stomach mucosa, they repair itself, but when this repairing mechanism become decreases, it will also cause the GERD. The other is hypothyroidism, CNS depression. Normally the lower esophageal sphincter is under the control of sympathetic nervous system and parasympathetic nervous system. So when we take CNS depression, it will depress sympathetic nervous system. So this will become relaxed and the stomach content can flow into the esophagus. There is due to gravid uterus, the pressure is exerted on the stomach, which can relax the lower esophageal sphincter and can cause the flow of stomach content into the esophagus. The other is alcohol and tobacco are also the risk factor. In tobacco, there is decreased salivation, and saliva contain the bicarbonate, which actually impair the buffering mechanism of the saliva in the esophagus. The clinical feature, there are two type of clinical feature. One is the esophageal and the base of the basis of location. One is the esophageal, the other is extraesophageal clinical feature. In esophageal, there is heartburn, and this heartburn can increase by bending, straining, and lying down. And the dysphagia is due to the inflammation of the esophagus, which in late cases cause fibrosis of the esophagus and cause narrowing of the esophagus, which can result into dysphagia. The other is water brush. So when the stomach content goes into the esophagus, it will cause the reflex mechanism, which will increase saliva secretion, and this increased saliva secretion is called a water brush. And the other clinical features include the chest pain, chronic cough, which is occur as a result of aspiration of the gastric content into the respiratory airway, and the asthma, which is occur as a result of stimulation of the central nervous system by the stomach contents. And the other is laryngitis and recurrent chest infection. The diagnosis, normally the diagnosis is based upon two things. One is the history and the other is empiric therapy of PPI. The history of if a person comes to the OPD or to the emergency, then start taking history. If the person has heartburn, dysphagia, water breath, chest pain, chronic cough or asthma, then you may suspect the GERD. And then start empiric therapy if the person is responsive to PPI, proton pump inhibitor, then you may suspect the case of GERD. So the endoscopy, if the person is not responsive to PPI, then you can do endoscopy. And endoscopy, a small tube is inserted into the throat and into the esophagus, and there is a minute camera at the end of the tube, and then the esophagus can be visualized and can visualize the inflammation and inflammation of the esophagus. So when the endoscopy is to be done, when there is failure to respond to PPI, when the person response to PPI is failed. PPI are drugs, proton pump inhibitor, which actually decrease the stomach acid. The other, when the symptoms are prolonged and cannot be suppressed by PPI. These include dysphagia, anemia, and weight loss. And if endoscopy is normal, if you have done endoscopy and the endoscopy is normal, check the lower esophageal pressure. If the pressure become decreased, then you may suspect that the person is GERD. And S24-hour pH monitoring. You should to check the pH of the pH. If the pH become acidic, every time you check the pH, then the treatment is based upon three things. One is lifestyle modification. You should to elevate the head of the bed. You should to lose the weight. The other is pharmacologic treatment. There are two type of drug mainly given in the GERD. The one is the PPI. PPI are a proton pump inhibitor, which actually act on the hydrogen potassium ATPase and on the parietal cell of the stomach, which actually decrease the acid production. The drugs are the drugs that are included in the PPI are dexlansoprazole, omeprazole, lansoprazole, esomeprazole, and rabeprazole and pantoprazole. And the other is H2 receptor antagonist, which actually decrease the binding of the histamine to the parietal cell, which cause decreased production of acid. These include the cimetidine, nizatidine, famotidine. So if the person is non-responsive and the person is unable to take long-term PPI, then you can recommend the surgery. And indication for the surgery, indication mean that when the surgery is to be done. So the first thing is when there is therapy failure, when the person is unable to respond to therapy. The other is when the person is unable to take long-term PPI, and when there is severe regurgitation, and when there is Barrett esophagus. When there is Barrett esophagus, so then the surgery should be done. And the other thing in the GERD is the complication. If the GERD is left untreated, it can cause the esophagitis, which is the inflammation of the esophagus, Barrett esophagus, in which the normal epithelium, which is the stratified squamous epithelium, is replaced by columnar epithelium. And the other is iron deficiency anemia. When there is GERD, there is loss of blood due to inflammation of the esophagus, which can decrease the iron within the blood. In the esophageal strictures in the gastrocorous. When there is hiatal hernia, it can cause the gastrocorous, which is the looping up the stomach around itself, and this is called a gastrocorous. So this was all about the GERD. So thanks for watching the video, and don't forget to subscribe, like, and share.